Topic number 4: Bleeding, clinical picture, diagnostics, methods of temporary and permanent stop of bleeding. Lecturer Shevchenko Alexander, Baltic Federal University Medical Institute, Kaliningrad, 2020. Classification of hemorrhage. We have 4 major types in classification: by anatomical feature, by time of occurrence, relative to the external environment, according to the clinical course. By anatomical feature. Major 3 types of bleeding by anatomical feature. It's arterial, venous or capillary bleeding. Arterial hemorrhage. When hemorrhage comes from an artery, it is called an arterial hemorrhage. Such hemorrhage is recognized by bright red color and is ejected in spurts with each systole of the heart. Venous hemorrhage is one which comes from a vein. It is characterized by dark red color and it flows out steadily instead of spurts. Blood loss is also copious in case of venous hemorrhage. Particularly when large veins are damaged, venous hemorrhage may become darker. When the patient is in the state of anoxia, either due to less oxygen given to the anesthetized patient, or there is airway obstruction, or there is sudden cardiac arrest. In case of the latter, the blood becomes even more darker due to excessive desaturation of oxygen in the blood. It is not very easy to stop venous hemorrhage. Penetrating wounds involving main veins may become fatal if it is not controlled properly. Similarly, venous hemorrhage from varicose veins is also difficult to control. As a first aid measure, a compression bandage and elevation of the limb is a good method to control bleeding for the time being. But such hemorrhage is best controlled by opening the wound and ligating the vein in the operation theater. Capillary hemorrhage is one in which hemorrhage comes from capillaries. In such hemorrhage, blood is bright red and oozes rather than flows out. As we see in this picture, we have 3 major types of hemorrhage: capillary, venous and arterial bleeding. Capillary not so big in volume as venous or arterial bleeding. It's not so dangerous, so venous and arterial. Arterial bleeding is more dangerous from all these 3 types. So capillary hemorrhage is slow, even flow, bright red color. Venous, steady dark red color. Arterial, spurting blood, pulsating flow, bright red color. And there are another 2 types of hemorrhage. It's a 4th type, it's parenchymal hemorrhage. On this CT scan we see zones with parenchymal bleeding. It means that some vessel, vein or artery is broken down and blood go to the parenchyma of the brain. And we have 5th type, it's mixed hemorrhage. It means when we have deal with severe trauma or car crash accident, different types of vessels involved. Arteria, veins, capillaries, all these types are involved in this trauma. This type of hemorrhage we call mixed hemorrhage. By time of occurrence. According to the time of appearance, hemorrhage can be classified into a primary hemorrhage, second recreational hemorrhage, and first secondary hemorrhage. Primary hemorrhage is one which occurs at the time of injury or operation. Reactionary hemorrhage is one which occurs within 24 hours of injury or operation. In majority of cases, reactionary hemorrhage occurs within 4 to 6 hours. Such hemorrhage takes place due to dislodgement of blood clots or slipping of ligatures. Third, secondary hemorrhage. This occurs usually after 7 to 14 days of injury or operation, thus is usually due to infection and sloughing of part of the arterial wall. Relative to the external environment. According to the source of hemorrhage, hemorrhage can be classified in two ways. Hemorrhage may be external or internal. External hemorrhage is one that is reviewed outside or seen externally. For example, when somebody is stabbed by a knife, we see the wound, we know it's bleeding because we see blood, it's external hemorrhage. Second, internal hemorrhage is one that is not seen from outside, or it is concealed hemorrhage. This type of hemorrhage is seen in bleeding peptic ulcer, ruptured ectopic gestation, fracture of major bones, ruptures of spleen or liver. Sometimes concealed hemorrhage may be reviewed as external hemorrhage. Examples of these are hematemesis or melena from bleeding peptic ulcer, hematuria from ruptured kidney, etc. About hematemesis or melena we talked later. So about when we talk about internal hemorrhage, here on this picture we see a ruptured spleen, and in this picture we see photo from fibroesophagogastroduodenoscopy. We see the ulcer, one ulcer, and we didn't see the origin of this bleeding in this picture, but we see the blood. According to the clinical course, we may deal with acute or chronic hemorrhage. When we talk about acute hemorrhage, we completely understand it. We have trauma, we have injury, we have acute bleeding. But what did we mean when we talk chronic hemorrhage? I give you 5 seconds to understand what does it mean. Okay, I think most of all students understand what means when we talk chronic. Every woman after they become more elder, then when they have deal with puberty, they have menses. It's example of the chronic hemorrhage. And if person have large bowel cancer, sometimes it bleeds, and we have a deal with chronic hemorrhage too in this case. When we talk about hemorrhage with bleeding, we must talk about defense reaction of organism against hemorrhage. Due to the flow of blood from the vascular bed, hypovolemia develops, a decrease in the volume of circulating fluid. The mechanism of vascular change is associated with a reflex reaction that begins with volume barrow and hemoreceptors of vessels. Irritation of the heart's volume receptors are large vessels leads to activation and hypothalamus structures, and then the pituitary and adrenal glands. Activation of the sympathoadrenal system leads to the following compensatory and adaptive change in the body. Vasospasm. Veins are the main capacitive part of the venous bed. They contain 7 to 75% of the circulating blood. Increased vein tone compensates for the loss of blood circulation capacity, up to 10 to 15%. The inflow of tissue fluid as a result of hypovolemia, as well as subsequently developing symptoms of small cardiac output and spasm of arterioles, the hydrostatic pressure in the capillaries decreases, which leads to the transfer of intracellular fluid to them. This mechanism in the first 5 minutes of blood loss can provide an influx of up to 10 to 15% of the blood circulation capacity into the blood vessels. Thus, auto hemodilution develops, which has the following effects: compensates for hypovolemia, improve the rheological properties of the blood, promote the leaching of red blood cells from the depot and restores the oxygen capacity of the blood. The physiological depots of the body include non-functioning capillaries, 90% of all capillaries, mainly the capillary network of skeletal muscle tissue, as well as the liver. Up to 20% of the blood circulation capacity is deposited, and the spleen, up to 16% of the blood circulation capacity. Next mechanism that defends our body from bleeding is tachycardia. It is associated with the impact of the sympathoadrenal system and allows you to maintain a minute heart volume at a normal level for a certain time. Oliguria. When hypovolemia occurs, the secretion of antidiuretic hormone and aldosterone is stimulated, which leads to an increase in water reabsorption and the retention of sodium and fluoride ions. Hyperventilation. Initially it is aimed at increasing the suction action of the chest and compensatory increase in blood flow to the heart. Then its development is largely associated with metabolic changes and violation of acid-base balance. Peripheral arterial spasm. This is a transitional stage between compensatory and pathological reactions in blood loss. The most important mechanism for maintaining systemic blood pressure and blood supply to the brain, heart and lungs. When these compensatory mechanisms are sufficient to maintain a normal blood circulatory capacity and bleeding stops, the condition of all organs and systems gradually normalizes. If the volume of blood loss exceeds the compensatory capabilities of the body, a complex of pathological disorders develops. On this picture you see two main ways of the coagulation cascade, but you must understand that all these mechanisms lead to one way. When we talk about coagulation, we mean that we have soluble in water fibrinogen that made insoluble in water fibrin, and that is lead to forming a blood clot. Okay, this is all about this. Clinical signs of hemorrhage. We have seen pale skin color, dizziness, weakness, tinnitus, drowsiness, thirst, blackout, anxiety and fear, fainting and loss of consciousness. Specific signs of internal bleeding: melena, hematohesis, hematophthis, hematomesis, coffee ground vomit. On this picture I show you a typical view of coffee ground vomit. You must remember this picture because if you will be a surgeon, you see this picture a lot. And when you try to remember what does it mean, hematophthis, you must remember that in Russia we have specialists who deal with tuberculosis. It's called phtisiatr. Phthisis means coughing with blood. Specific types of hemorrhages: upper head, intracranial hemorrhage, bleeding in the skull; cerebral hemorrhage, a type of intracranial hemorrhage, bleeding within the brain tissue itself. We see this example on the third type of hemorrhage, parenchymal hemorrhage. Intracerebral hemorrhage, bleeding in the brain caused by the rupture of blood vessel within the head. See also hemorrhagic stroke. Subarachnoid hemorrhage implies the presence of blood within the subarachnoid space from some pathologic process. The common medical use of the term subarachnoid hemorrhage refers to the non-traumatic types of hemorrhages, usually from rupture of a berry aneurysm or arteriovenous malformation. The scope of the article is limited to these non-traumatic hemorrhages. Eyes. Subconjunctival hemorrhage, bloody eye arising from a broken blood vessels in the sclera, whites of the eyes, often the result of strain, including sneezing, coughing, vomiting, or other kind of strain. Nose. Epistaxis. Epistaxis means nosebleed. Mouth. Tooth eruption, losing of a tooth. Hematemesis, vomiting with fresh blood. It's very important too. Hematophthisiss, coughing up blood from the lungs. Lungs, pulmonary hemorrhage, gastrointestinal, upper, lower and occult gastrointestinal bleeding. Urinary tract, hematuria, blood in the urine from urinary bleeding. Gynecologic, vaginal bleeding, postpartum hemorrhage, breakthrough bleeding, ovarian bleeding. This is potentially catastrophic and not so rare complication among lean patients with polycystic ovary syndrome undergoing transvaginal oocyte retrieval. Anus, melena, which is example of upper gastrointestinal bleeding. Hematochezia, lower gastrointestinal bleeding or brisk upper gastrointestinal bleeding. Vascular, ruptured aneurysm, aortic transection, iatrogenic injury. Lab signs: drop in blood pressure, quickening of the pulse rate, anemia, low hematocrit, low red blood cells and low hemoglobin, and acute respiratory failure, respiratory rate more than 21. Oliguria. When we talk about oliguria and we have an adult patient, we must talk about 0.5 milliliters per kilogram in hour. It's equal to normal urine output in hour. If we have less than 0.5 milliliters per kilogram in hour, we talk about oliguria. By severity, Russian classification: easy hemorrhage from 10 to 15%, average from 15 to 20, heavy 21 to 30%, and massive blood loss is more than 30% of blood circulating capacity. It's more complicated in Russian classification. We have 3 different columns in this table: mild, moderate and severe blood loss. Why it's better than this classification? Because we can understand easy, average, heavy and massive blood loss means we have this or this examples in table. We have red blood cells count, hemoglobin, heart rate, systolic blood pressure. It means less here in the table, and here more. This table means globular volume. Its lab value, we cannot use it in practice. It doesn't matter anything. But take a look on classification of hemorrhaging by the American College of Surgeons. It's doctors who deal with emergency medicine, acute trauma, life support. You must remember this classification for whole your life. Class first, hemorrhage. Involves up to 15% of blood volume. There is typically no change in vital signs and fluid resuscitation is not usually necessary. Second class of hemorrhage. Involves up to 30% of total blood volume. A patient is often tachycardic, rapid heartbeat with a reduction in the difference between the systolic and diastolic blood pressures. The body attempts to compensate with peripheral vasoconstriction. Skin may start to look pale and be cool to the touch. The patient may exhibit slight changes in behavior. Volume resuscitation with crystalloids, saline solution of lactated Ringer's solution is all that is typically required. Blood transfusion is not usually required. Class 3 hemorrhage involves loss of up to 40% of circulating blood volume. The patient's blood pressure drops, the heart rate increases, peripheral hyperperfusion with diminished capillary refill occurs, and the mental status worsens. Fluid resuscitation with crystalloid and blood transfusion are usually necessary. And for class of hemorrhage involves loss more than 40% of circulating blood volume, the limit of the body compensation is reached, and aggressive resuscitation is required to prevent death. Estimated blood loss based on patient's initial presentation. It's acute trauma life support. It means it's American College of Surgeons. We have 4 classes. We have blood loss in persons, which pulse rate we expect, systolic blood pressure, pulse pressure, respiratory pressure, urine output, and mental status of this patient. And what is more meaningful in this table, we have recommendation to initial fluid replacement. In Russian recommendation we have colloids. In acute trauma life support recommendation we have only crystalloids and blood. You may ask why? Because when we add some blood to the patient, we gave him some coagulating factors. So when we give patient a blood with coagulation factors, we can provide fibrin soluble in water to insoluble fibrin. And insoluble fibrin is the first stage of the blood clot forming. You must remember this. As we say, in surgery you must deal with endoscopic bleeding of the upper gastrointestinal bleeding. You may deal with gastric ulcers. And we have 4 classification of gastric ulcers. First A, it's protein arterial bleed. 1B, oozing bleeding. Second A, non-bleeding visible vessel. Second B, adherent clot. Second C, black hematine ulcer base. And 3, clean ulcer base. Clean ulcer base, it means no bleeding. This is no origin of the bleed, of the blood. No bleeding. What is important to the surgeon? Because we have a rebleeding chance in persons. If we have 1A type of hemorrhage on the endoscopic picture, we must understand that up to 90% it can rebleed again. Here you can see all these types of hemorrhage in pictures, endoscopic pictures. It's jet from the artery, it's very severe bleeding. On the second picture we have oozing bleeding. Here we have visible vessels with a clot in the end of this vessel, adherent clot, only black spot, and clean base. White clean base, it means you see fibrin. Another one very important them in this case, measurement of blood loss, because we must give all the blood which patient lost in the time of the operation, we must give them again. It is often important to measure how much the patient has lost blood. This amount should always be replaced. Whatever methods adopted to measure blood loss, they do not give the actual figure. The blood loss detected by the methods is usually less than the actual loss, because a considerable amount of plasma is lost into the interstitial tissues and considerable amount of water is lost via lungs from the wound and by evaporation of sweat from the skin. This loss of plasma and water constitutes approximately 20% more than the blood loss detected by various methods. The best methods to detecting blood loss is by weighting gauzes soaked with blood. The other methods are measurement of swelling in case of bleeding from fractures and measurement of blood clot is in hemorrhage. Weighting of gauzes. This, of course, is the best method of measuring blood loss during operation. The swabs are weighted before they are used, and they are weighted again after they are soaked with blood and thrown individually into a collecting basket. The difference of weight is the amount of blood loss. 1 gram is equal to 1 milliliter of blood loss. As mentioned earlier, it cannot give the actual amount of blood loss, and it should be multiplied by a factor of 1 in case of moderate operation like partial gastrectomy or radical mastectomy. In case of longer operation like abdominal perineal operation, the swab weight in total should be multiplied by a factor of 2. Second, measurement of swelling in closed fractures. Not only in case of fractures, if we have severe trauma and we expect fracture, we use this method too. In case of moderate swelling and closed fractures in the tibia, blood loss estimated to 1,500 milliliters. In moderate swelling in case of fractured shaft of femur, it estimates blood loss about 2,000 milliliters. Thorax up to 2,500 milliliters, abdomen up to 2 liters, pelvic bones up to 3 liters in average, hip bone up to 2 liters, shin bone up to 800 milliliters, humerus up to 600 milliliters, forearm bones up to 500 milliliters. Measurement of blood clot. When the collected blood clots are kept in a pot and measurement against a clenched fist of the patient, total blood clot of the size of the clenched fist is equal to 500 milliliters of blood. Hemostasis. We deal with two types of hemostasis, temporary and final. Temporary hemostasis we make when we give the patient first aid, when we must transport this patient to the hospital. And final hemostasis we make in the hospital, most of all in the operating theater. Temporary hemostasis. First of all, elevated position of the limb. Second, applying a pressure bandage. Finger pressure on the artery in the wound, so it's venous, it's artery. Maximum flexion of the limb, it's artery too. Applying a hemostatic clamp. It can be artery and vein. Applying an Esmarch tourniquet, only artery. Tamponade. When we deal with tamponade, when we have wound where we cannot do the pressure bandage or Esmarch tourniquet. If we deal with wound of the abdominal wall or our back, we can press some gauze to this wound to try to tamponade this wound and stop bleeding. Hemostop. Hemostop, it is a special device military uses often It makes from the chitin, and we can add it to the wound, and it tamponate wound too. You can see on the internet how it looks like. Final hemostasis. We have 4 different types of final hemostasis: mechanical, physical, chemical, and biological. When we talk about mechanical methods, we have 3 different types: ligation of the vessel, you see it here; vascular suture, see it here; and prosthetics of the vessel. Physical methods: cold, cauterization, and laser. Most often we use cauterization. Cold. Cold used only in case of mild, not severe bleeding. If we have deal with capillary bleeding, okay? Not with arterial or venous bleeding. It's prohibited. Chemical methods: vasoconstrictors, epinephrine, pituitrin that increase blood clotting, hydrogen peroxide, aminocapronic acid, tranexamic acid. We must understand that we deal with hydrogen peroxide when we deal with mild hemorrhage too. And when we talk about biological hemostasis, we deal with physiological process. We can help it to add some plasma to the patient or blood clotting factors to the patient intravenously. We have some blood-saving technology in surgery: reinfusion, autotransfusion, transfusion. Reinfusion of blood is a reverse transfusion of blood into the vascular bed of a patient that is lost as a result of surgery, trauma, or pathological processes. Indication for blood reinfusion. Indication for blood reinfusion are significant operating, postoperative, post-traumatic blood loss, as well as bleeding into the internal cavities of the body. In principle, it can be that any blood loss under conditions that allow the use of spilled blood can be and should be replaced reinfusion. Reinfusion of blood is a therapeutic measure that saves the patient from unexpected massive bleeding. High efficacy of blood reinfusion in emergency surgery for ruptures of spleen, liver, kidneys, in periectopic pregnancy, operation on large vessels, chest organs, and a number of other surgical interventions was noted. Contraindication to blood reinfusion. First, purulent contamination of spilled blood. You may ask why. I can answer you that if we reinfuse purulent contaminated blood, we can lead to this patient to sepsis. Contamination of spilled blood within intestinal and especially colonic contents. The reason is the same. Surgery for malignant tumors, because we can help this tumor to metastasize, because some little particles of the cells can be in this blood. And renal failure patients, because we add some conservants into blood before we add it to the before we reinfused it, and patient with renal failure cannot deal with it. Autotransfusion. Autotransfusion is a process wherein a person receives their blood for a transfusion which person donated earlier. Transportation of a patient with bleeding. First of all, it is necessary to stop external bleeding. Then lay the patient on his back on a stretcher, lower the head and the stretcher, put a roller under his feet. During transportation, it is necessary to monitor blood pressure, pulse rate, consciousness and the condition of the bandage. If there are signs of acute blood loss during transportation, intravenous infusions of blood substitutes for crystalloids and, if necessary, colloids are carried out. Which With the increase in acute circulatory insufficiency, cyanosis, shortness of breath, pronounced arterial hypertension, and tachycardia, it is necessary to conduct self-transfusion of blood, for which the patient's head is lowered below the heart level and the lower limbs are lifted at an angle of 30 degrees. This technique increases blood flow in the lungs and myocardium, preventing the development of irreversible change in vital organs. In case of pulmonary bleeding or bleeding into the pleural cavity, the patient is transported in a semi-sitting position. In case of gastrointestinal bleeding or bleeding into the abdominal cavity, transportation is carried out strictly in a horizontal position to prevent the development of fainting or collapse. So, I hope you enjoyed this video. Thank you for your attention. I hope you know now more about hemorrhage and how to manage it. Thank you for your attention.